Morning and welcome to my YouTube channel, Pain Free Partha. Today, I am going to tell something about vasopressors and inotropes and the difference between these two things and how to use in a scientific manner in specific clinical scenarios. Sometimes it may not be completely evidence oriented, but I will give a physiological explanation of why I am using like that. Now, a brief intro about the receptors. Alpha 1, it is in the blood vessels, vasoconstriction. Alpha 2 is about against sympathetic because it decreases noradrenaline from the sympathetics. That is what clonidine and dexmedetomidine do. So alpha 1, vasoconstriction. Alpha 2 may be vasodilatation. So that is what we should understand. I am talking about agonist. Beta 1 is heart rate, force, rate, excitability. That is inotropy, chronotropy, and dromotropy increased. Beta 2 is a smooth muscle, bronchus, uterus, bladder, etc. Beta 3 is urinary bladder slowing. Dopamine 1 is vascular smooth muscle, vasodilatation. Postganglionic sympathetic nerves inhibits any release dopamine 2 in smooth muscles. Renal mesenteric may be causing vasoconstriction. Now I am giving you the simple thing, alpha and beta. Alpha 1, alpha 2. Now the adrenaline is basically alpha 1, alpha 2, beta 1, beta 2. Okay. Alpha 1 is vasoconstriction. Alpha 2 is clonidine, that vasodilatation. Beta 1 is inotropy, chronotropy, dromotropy. Beta 2 is smooth muscle, vasodilatation of the bronchus, uterus, bladder, etc. Now adrenaline does all these things. Okay. Now we go here. Noradrenaline has not got much of beta 2 action. So it's predominant vasoconstrictor. There is no smooth muscle dilatation. Okay. So this is also a little less with norad, but there is some beta 3 action. Now I'm going to this terbutaline, salbutamol, levosalbutamol. These are all beta 2 agonists. Isoprelin has got no action on alpha. It is more of beta 1. So good chronotropy, that is the ideal thing for isoprelin. Pulse rate rise, isoprelin. Pulse rate rise, atropine, then isoprelin. Oxymetazoline, we know, yes, alpha 1 vasoconstriction. Phenylephrine is predominantly alpha 1. It does not have alpha 2. But clonidine and dexmed has got alpha 2. Dobutamine is a good inotropy with here C vasodilatation. This is what is the dobutamine. Dopamine has got beta 1, alpha 1 action also. See here, there is no dobutamine has got not alpha 1 action. Ephedrine and ephedrine, alpha 1 and beta 1. So there are so many drugs like inotropes, vasopressors, vasodilators. Inotropes increase the force and contractions. Chronotropy increases the rate. Dromotropy increases the excitability and conduction. There is something called a lucitropy, better diastolic relaxation. This is what inotropy, chronotropy, dromotropy, and lucitropy. Now, vasopressors are drugs that causes sympathetic like vessels constrict. Vasodilators causes muscle dilatation. These are the things. Many drugs have got dominant actions. Okay. Dobutamine, if you're giving high dose, it may be also acting on alpha slightly. So all these things are mainly dominant actions. Precise doses, preferably through a central line. Milrinone is a phosphodiesterase inhibitor which increases CAMP. It increases heart rate, stroke volume, and output, but decreases SVR. That is the advantage. I will give you a better picture later. Angiotensin 2 is a vasoconstrictor. RAS system, vasoconstrictor, calcium increases, vasoconstriction. Levosimendan is also a calcium sensitizing agent. Vasopressin is, see the name itself is indicate. It's like vasopressors as noradrenaline. Infusions of angiotensin 2 has also been reported. Now, vasopressors increase vasoconstriction, Increased SVR leads to increased MAP. Inotropes increased cardiac contractility. Now you see, the MAP is increased by SVR in noradrenaline. MAP is increased by increasing cardiac output is dopamine. MAP is increased. Dopamine causes this to increase and here, while NORAD causes this to increase here. If NORAD causes this and cardiac output is down, then your MAP may not be a good indicator. The major vasopressors are NORAD, vasopressin, phenylephrine, and somewhat epinephrine. Dopamine has got inotropic. Dobutamine and milrinone are inotropes with some vasodilatation. Afterload decrease, good inotropy. That is what we want for being dysfunction, myocardial dysfunction. Now there are two pictures like this. Don't worry, the picture will come again. Now I am telling about beta 1 receptor, dobutamine or adrenaline or whatever it is, dopamine. So this causes adenylate cyclase to stimulate. ATP is formed as AMP, cyclic AMP. This is the main pivot. Cramp increases calcium, calcium increases your contraction. Okay, calcium increases this thing and actin myosin contractions. Cramp is also increased by milrinone. What does milrinone does? Phosphodiesterase inhibitor. Cramp is destroyed by phosphodiesterase and this phosphodiesterase is destroyed by milrinone. So cramp is increased calcium. Okay. Now this is one side. Another side is about levosimendan, calcium directly increased. Milrinone is now we know digoxin, sodium potassium pump inhibitor. Calcium 3 is in and calcium 2 is. So that is why it is causing calcium to increase and the same actin myosin. Circa is sarcoplasmic reticulum calcium ATPase. Here DHPR is dihydroprotein receptors. This is ryanodine receptors. Ryanodine receptors. These drugs have come up now. Yes, that is why we know dobutamine, beta. Okay, heart rate is increased and just SVR is decreased. See, because it vasodilates, cardiac output is increased, PVR is decreased. So ideal use is cardiogenic shock. Milrinone is also cardiogenic shock, but here the effect on cardiac output is more. But here you see, SVR decreases more with milrinone. But isoprenaline, only heart rate increase. Cardiac output may be increased, but nothing much here. But isoprenaline is indicated in refractory bradycardia. Now you see vasopressin is a vasoconstrictor, ideal in distributive shock in sepsis. Phenylephrine is also distributive type of shock, that is ideal for spinal anesthesia. So norepinephrine, NORAD, see here SVR increase. So what we want is, where we want SVR to rise is in septic shock, NORAD. Epinephrine is ideal in anaphylaxis. Dopamine has slowly gone out of routine use. I'm not going into this because software have come to calculate. Now we have cardiogenic shock. I have one more video on approaches to shocks. That's a different thing. Hypovolemic, distributive, obstructive. Hypovolemic, what is the role of inotrope? Very minimal. Give fluids, give blood, give fluids, 2 cannulas. So extremely, patient has got diarrhea for 10 to 20 times. What is the role of vasopressors? Give IV fluids. Now you have a cardiogenic shock. Okay. Now the heart is not pumping well. Now you make the heart to pump and also the afterload to decrease so that the heart pumps very easily, like cycling from a downstream mountain. So that is the advantage of dobutamine in cardiogenic shock. Slightly give diuretics if the fluid is overloaded. Distributive shock, septic shock, anaphylaxis, and neurogenic. Septic shock, NORAD, or vasopressin anaphylactic shock. There is only one drug, that is adrenaline, because adrenaline counteracts everything. it counteracts laryngeal edema, it counteracts histamine, it counteracts shock. Obstructive shock, for example, pericardial effusion. Which inotropy you are going to use? Pulmonary embolus, pneumothorax. Nothing. You remove drain the pneumothorax, drain the pericardial effusion. Fluid resuscitation for all types of distributive shock is okay. Noradrenaline and vasopressin for septic shock. Adrenaline, phenylephrine for neurogenic. Adrenaline for anaphylaxis. Now I will go to a scenario. Now a 54-year-old man develops chest pain, acute anterior infarction. Pulse rate of 75, BP of 60. See, this is a shock. Acute MI, it's a cardiogenic shock. Pulse is regular volume, no other history of any, now which is good. Dobutamine, 2 to 20 mg, because good inotropy, some chronotropy, mild vasodilatation. SVR decrease, afterload decrease, good output. See the urine output. We think that the infarction causing myocardial dysfunction and decreased inotropy is the cause of hypotension. It is cardiogenic shock. So give dobutamine. In most cases of cardiogenic shock, there is some vasoconstriction to pick up the blood pressure because now the heart is not functioning. So the MAP wants to increase. So the blood vessels constrict. Okay. Now if we start dobutamine, heart will pump effectively and this vasodilatation is on. So sometimes BP may fall. So sometimes we may need to add dobutamine with some NARAD so that there is not much of vasodilatation. Dobutamine is start acting. No change needed in renal failure. Prolonged use, it will desensitize beta receptors. So tachycardia may be there, but noradrenaline will cause bradycardia. That is the advantage of combining dobutamine with some minimal dose of NARAD. This is about C1. Scene 1, myocardial dysfunction. Now we'll go to scene 2. A 42-year-old underwent manual anal dilatation and IV sedation. Developed a heart rate of 45. This is neurogenic shock. So ideally, if the heart rate alone is decreased, BP is maintained, atropine is not picking up. So the next drug is isoprolane, or sometimes you may need to give adrenaline. So this is what is, because isoprolane is the drug of choice for negative chronotropic effect. It is an excellent positive chronotropic drug. Chrono means rate increase. Bromo means excitability increase. Inotropy means contractility. Lucitropy means relaxation. Isoprenoline is a powerful chronotropic. So sometimes it may not be available. Vasodilatation associated adrenaline is another choice. Can be given in a peripheral line in case of emergency. Sometimes you can ask, because it's 160, 45 per minute, remove the stimulus. Don't do a manual annotation. Wait, utropin will clear. So that is one advantage. You should stop the stimulus. Don't think about isoprolane, adrenaline at all. Ask the surgeon to stop the stimulus. Now we have third scenario. A dilated cardiomyopathy patient on ACE inhibitor, diuretic, atorvastatin, NIHA 2, EF of 32. Now he doesn't take drugs regularly, and there are mild basal crepitations with BP of 90-60. Now, this is a chronic problem, acutely decompensated, because chronic problem means your sympathetics will be exhausted. So you need to have a drug which overcomes your camp side, CAMP, anticyclists, all these things. So the drug of choice may be levosimendan. So levosimendan is an inodilator. Again, you see, acutely decompensated heart failure, increased contractility, direct calcium, vasodilatation through opening of potassium channels, cardioprotection through the opening of myocardial. So myocardial protection, vasodilatation, increased cardiac contractility. These are the advantages of levosimendan, especially in a chronic problem, acute decompensation. 6 to 12 microgram per kg bolus. Usually we give 1.1 microgram per kg per minute for 1 day. 1.5 days. So pulmonary hypertension is better and renal perfusion is better. It's the advantage of levosimendan. See, if you're using levosimendan, you think again the same as dobutamine. Your vasodilatation is not beneficial. Think some adding of iron. Severe mitral stenosis with shock, 70 systolic, which I know Prasar will work. You have to open the valve. Another senior, 46-year-old female, developed backache. Injection diclofenac IM was given. In 5 minutes, patient was conscious, but BP was not recordable with wheezing. This is a case of acute anaphylaxis. So if the BP is not recordable, you can give IV if possible, or IM if possible, or otherwise intratracheal is also present. So anaphylaxis, distributive shock, adrenaline. That is one point. Now, if you give diclofenac here and patient allergy, you should not give a diclofenac adrenaline here. You should give adrenaline here because in the muscles, adrenaline will vasodilate. In the subcutaneous tissue, adrenaline will vasoconstrict. So if you have given subcutaneous test dose and the patient has developed anaphylaxis, you can give adrenaline here. But IM, adrenaline, no IM there. Bronchodilation, nasoconstriction. There is here you can see wheezing. I already told this patient there was wheezing. Inotrope, chronotrope, everything, histamine release, everything it contracts. A 35-year-old female with 50% burns, resuscitated with adequate fluid is there, but still 80-60. Burns. Now, acute myocardial dysfunction may be there in burns. So we can add some dobutamine because we have resuscitated with adequate fluids. Because think of, we don't want ischemia in that area. Neurogenic shock means uninhibited vagal tone, vasogenic and cardiogenic instability. So NARAD or adrenaline starts IV fluids fast. The next scene is a diabetes uncontrolled with pelvic sepsis. The patient has developed an uterovaginal sepsis. Conscious pulse rate is 150, BP is 80 systolic. That is the drug of choice is noradrenaline. Okay, septic shock noradrenaline. The next drug is vasopressin. Now you can see in this is not the things are moving very fast, but I will feel this first few hours immediately give resuscitation of fluids, then start NARAD sepsis, then start vasopressin. All these things we can give a stress dose steroids and starts other drugs. So fluids, norepinephrine, vasopressin, steroids. Refractory septic shock, yes, angiotensins 2 can be added. You are weaning from CPP, pre-existing LV dysfunction. There is a refractory cardiac failure, dysfunction. We can use milrinone because it has got inotropy with relaxations, diastolic betterment. So that is what is called lucitropy. Milrinone. How does it act? Phosphodiesterase 3 inhibitor. Campaigns increased. So LV dysfunction from bypass, it's temporary. In the neonatal population, it is used to do persistent pulmonary hypertension. Problem is renal problems and arrhythmias and hypotension. Dopamine has slowly become good drug. It was 1 to 2 miles, good cardiac. Then they say respiratory effect, renal effect, all these things have gone. Slowly it has gone into the baskets. Complications of vasopressors, hypoperfusion, skin ischemia, mesenteric ischemia, gut ischemia. The gut ischemia is there, it will go into bacteria. Keep an eye on the cardiac output and urine output. Okay, your BP is fine, but output is decreased. I have already told MAP is equal to cardiac output into SVR. We are increasing the SVR, decreasing the output so that your pressure is maintained, but no urine output. That is what the situation we don't want. Increase the SVR, maintain the BP, and don't be happy because cardiac output is decreased, urine output is decreased, patient will slowly go into acidosis. Your MAP is fine, and you are correcting acidosis. Complications, excess tachycardia may be problem with acute myocardial infarction, hyperglycemia, skin extravasation, and necrosis. Now you got a beta blocker poisoning. You can give beta stimulant? No. Glucagon is the drug of choice for beta blocker poison. Insulin is also having inotropes. We don't have beta receptor, so then we need to give glucagon. There are other drugs like calcium in form of gluconate, steroids, and pimobendan is both inotrope, inodilator. Phenylephrine is a pure alpha agonist. That is what is used in spinal anesthesia, especially if we don't want tachycardia or tachyarrhythmias. Estroxane is a sodium potassium ATPase inhibitor like digoxin. Calcium pump increased and inotropic lucitropic effect. No vasodilatation. Omecamtiv is a cardiac direct myosin activator. These are the two new drugs. So whenever we are using inotropes, beware of pheochromocytoma, idiopathic hypertrophic aortic stenosis, very dangerous condition. No inotropy for IHSS, give beta blockers. So pheochromocytoma, aortic aneurysms, and MAO inhibitors. Drugs and multiple receptors. Drugs and different doses. Drug action and reflex action. Phenylephrine will cause bradycardia. Norad will cause bradycardia. All these things, reflex actions. Fluid resuscitation is very important in most of the things. Drugs, what is a drug and what is the choice? So, for example, you are giving heparin and then vasoconstrict. Your heparin will not. Now you see here, if you give catecholamine, it comes through beta 1. CAMP, adenylate cyclase is stimulated. CAMP causes calcium, dromotropy, inotropy, and chronotropy. Now you can see this through beta, if it comes, protein kinase, calcium uptake, and vasodilatation. This is what dobutamine does. But what happens in adrenaline and noradrenaline is the alpha is stimulated. Inositol triphosphate is increased, calcium is increased, vasoconstriction in the blood vessels. Not through this. This action is alpha actions. Now you take milrinone. It is a phosphodiesterase 3 inhibitors. So CAMP is demolished by PDE. PDE is demolished by milrinone. So CAMP is increased by milrinone. Again the calcium, inotropy, chronotropy, and again the vasodilatation. It also causes sarcoplasmic reuptake problems are solved. So lucitropic actions with milrinone. Now I give digoxin, sodium potassium ATPase, calcium. Estroxime is also there, but estroxime has also got action on the cell count. Now you see there are other drugs like Omecamtiv, direct myosin stimulation inotropy. Levosimendan, it increases intracellular calcium, causes myosin to increase inotropy. So this is the basic picture that we should always remember before starting or approaching any type of shock. So what is the definition? Receptors, action, target types of shock, scenarios, and complications.